Isolated ventricular septal defect. Anatomy, pathophysiology, and pathology. Defects can occur at any level in the ventricular septum. A small defect causes a high-pressure left-to-right jet but no hemodynamic abnormality. Large defects with a shunt can eventually result in Eisenmenger's syndrome. Small defects in the membranous part of the septum noted during childhood often close by the age of 2 years. Epidemiology. Ventricular septal defect, VSD, is the second most common congenital malformation of the heart, accounting for 20% of all congenital malformations. Clinical presentation. Small defects with no shunt are usually asymptomatic and detected incidentally, secondary to the identification of a cardiac murmur. Defects with a significant shunt present with progressive dyspnea, reduced exercise tolerance and eventually cyanosis in adult life. Physical signs. Pansystolic murmur and thrill at the lower left sternal edge. Signs of pulmonary hypertension. Clubbing and cyanosis of Eisenmenger's syndrome. Investigations. ECG. In a small VSD it is often normal. However, with progressive worsening of the shunt there may be atrial arrhythmias, e.g. atrial fibrillation, right axis deviation, and right ventricular hypertrophy. Chest radiograph. Normal in small defects. With progressive shunts there are radiographic signs of pulmonary hypertension, including cardiomegaly, enlarged pulmonary trunk and reduced lung markings in the periphery. Echocardiography. Used to confirm diagnosis and calculate shunt. Treatment. Surgical closure of the defect should be considered. Small VSDs without a shunt do not need closure. VSDs with a hemodynamically significant shunt should be closed if pulmonary hypertension is not severe and/or reversible. Prognosis. Long-term outcome in patients who have successful closure of their VSD prior to development of pulmonary hypertension is excellent.